Dr. Salme, you've been in the chiropractic industry for 25 years now. As an expert, I was actually one of the questions I wanted to ask you when people generally, what specific symptoms somebody who doesn't know the chiropractic industry, in other words, the norm would go to a GP. In other words, you have a headache, a head pain. Like, I'm just curious to know, like, what some specific signs and symptoms instead of going to a GP, perhaps a chiropractor like yourself is actually the remedy to the pain, the cause.
Well, so a very good question. I think what a lot of people don't know is that as a chiropractor, you're educated as a primary health contact nutrition. What that actually means is that we're taught to diagnose, but secondly, when a patient comes into our practice or into our reviews as a chiropractor, regardless of what they're presenting with, whatever symptoms they are, we have been educated to assess, examine that patient and say, okay, this is a chiropractic case. You're in the right place. We can treat you for whatever. Or actually, you've got a bit of a problem here. This is a heart condition, lung condition, whatever the story is, and then initiate the appropriate referral. So that's probably the thing that probably needs to sit right at the top is that, if you're suffering with headaches, neck pain, back pain, which is kind of the bread and butter stuff that we see as chiropractors.
Which most people go to GPs. So that's why I'm curious.
Absolutely, it's true. And with due respect, I mean, in terms of what the GP is going to do for you, they'll do a couple of tests and make sure there's no major red flags going on. But their course of action is to give you painkillers or anti-inflammatories. Now, that is an approach. If that works for you and you really don't have time in your day to stop and think about what's going on, to go to take a painkiller or an anti-inflammatory may well get you in a little bit of trouble. It's not going to fix your problem. No, as this is often the issue, is that when you get pain, when your body gets pain or exhibits pain, it's an alarm system going off. It's saying, hey, you need to pay attention here. I'm not coping with what's going on here, and I need you to do something about it. For us to be able to take a painkiller or an anti-inflammatory is a very quick and often simple solution, but we haven't fixed the problem. So if you're lying in bed at night and all of a sudden your house alarm goes off, do you just press the stop button and go back to sleep? Or do you actually do something about going to check what's actually going on? And when we take painkiller and anti-inflammatory, we're essentially ignoring the alarm. It may be prudent at that point in time, you don't have time in your day, you don't have time in your schedule to actually get to the bottom of what's going on. And it may suit you to take a painkiller and anti-inflammatory. But understand that for your body to hit the panic button and to start screaming and shouting at you with pain, it's not coping. So for you to just put a Band-Aid over the top of it to take a stop pull is not fixing your problem. So yes, bread and butter stuff for us as chiropractors, neck pain, headaches.
Okay, it's slowly, doc. Okay, when you say headaches, so headaches in general, in other words, a normal headache, I mean, I think in this day and age with the stresses of our day-to-day life, it's normal. But I mean, are we talking about headaches that for days, weeks, every morning you wake up or you got this excruciating pain? So that would be symptom number one to either decide, okay, GP, chiro, and in your case, you specialize in that. Okay, so
Well, firstly, to get headaches and head pain is not normal. Yes, we live in a very stressful environment. Yes, we've got all sorts of things coming at us from all different angles. And a lot of people out there suffer with headaches and head pain. The crux of it is you need to try and understand or know where it's coming from. And if you do, you can then manage it. And as I said, there are a million and one reasons why you might have a headache or a head pain. But if you have a good idea of where it's coming from, you can manage it appropriately. It's not good enough to have a headache, wake up with a headache, not know where it's coming from, take a painkiller, anti-inflammatory, and carry on. That kind of warning sign is not a normal warning sign. If you're lucky enough to only get headaches once in a blue moon, fantastic. There are people out there who get outrageous headaches every day of their lives. They've got migraines, they've got all sorts of pain syndromes associated with their headaches and their head pain that we need to get an understanding of maybe where this is coming from, because it could be something fairly critical. And if we don't manage it properly, that problem is only going to escalate and get worse and worse. So firstly, You need to consult with someone who's going to examine you properly and at least start the process in terms of trying to find out where this headache is generated for. Now, that's not to say that chiropractors fix all headaches. Far from it. Where we are incredibly valuable and get incredibly good results is in a very small pocket of headaches and episodes. But if you fall into that pocket, gosh, it will change your life.
Yeah, tell us about the pockets. Yeah. So, especially for somebody who's never heard of chiropractic, and this is the first time they actually hearing a chiropractor speak about your industry and what you do. So, this is point number one. I think it's so. Sorry to interrupt.
No, not at all. So if we come back to your original statement that you made about and us living in a stressful environment and all these things that come at us every single day. So the majority of that would create what we call a cervicogenic headache. And what we mean by cervicogenic headache is any structure that is involved with the head and neck. So whether it's a joint, whether it's muscles, ligaments, and your posture that's related to all of that, anything directly related to that that could generate a headache would be considered a cervicogenic headache. Now, chiropractic has amazing results with cervicogenic headaches. As I say, it's a rather small pocket of the bigger picture of what.
And you mentioned one of the symptoms is posture. Please elaborate. That's quite interesting. In other words, how we sit, how we walk, how we.
So posture is an interesting one here because it's very relevant, it's very real, but it can also be used as an easy out in terms of expanding why someone's got neck pain, headaches, jaw pain, or whatever the story is. And unfortunately, the majority of us spend a lot of time sitting, and we were never designed to sit. And that's probably the biggest contributor to where we start getting posture-related pain syndromes. And essentially what ends up happening is the shoulders tend to droop forward, and that tends to drift our head forward as well. We're busy looking at computer screens, or we're trying to look at phones or iPads or books, so that you then lift your eyes up to see where you're going, what you're doing, in order to suddenly create this typical sort of forward shoulder posture, hokey chin scenario.
Which over time that causes headaches, migraines, etc.
So it puts an inordinate amount of pressure on the base of your neck into your sort of C5, C6, C7 area, and also into the base of your skull. And now that could be mechanical. Those joints could lock up in jana, but the locker effect of that is into the soft tissue. It's into the muscles, the ligaments and tendons in that help control the function of your head and neck. And your body will do an amazing job at compensating, coping with a lot of that for a long time. But eventually you're going to run out of the capacity to cope and compensate. And once you run out of that capacity and you go through the threshold that triggers off your alarm signal and your pain response, now you're in a world of trouble. And I mean, that could come across from clenching and grinding. And which also comes from a stress response. And when you're all of a sudden in this sort of posture, the head's poked forward and now you stop grinding and clenching, your jaw is automatically sitting in a disadvantageous position posturally. And now you're grinding and clenching with the teeth. That just triggers off a whole nother world of myofascial pain syndromes, headaches, sinus pain, hearing and balance disorders, and it's all linked. And I'll come back to the original point, is that as a chiropractor, we may not be able to fix all of that stuff for you. We can do a lot to help you improve and manage it, but you may well need to be referred to an ENT specialist, a vestibular specialist, physio who specializes in that style, and chiropractors who work more on neurological imbalances, subtle neurological imbalances that will help you get there. And I guess what I'm getting at is that we can contribute a huge amount to your relief and management of this pain, and without having to go down the road of a pathological issue that might be going on. So a lot of this stuff is a precursor and a warning that your body's not coping. The longer we leave it, the further down the path you go, the more likely you are to delve into a pathological scenario. Once you're in the pathological scenario, there's very little that we can do from a conservative therapy perspective to help you with that management. We could give you palliative relief, and you may feel a little bit easier, a little bit better. But once you're in a pathological state, your body's now fighting to try and keep you going every single day. And there's nothing that's going to reverse that process. And now it's all about palliation. Can you do something for me just to alleviate some of the pain or discomfort? You're not going to get back to a place where on a day-to-day basis, you actually feel like you can cope and you can manage pain-free. So don't ignore those warning signs. There's something driving that. And the longer you ignore it, the more trouble you're likely to get into. Where we can help a lot is the earlier we get it, the earlier we pick up on that initial pain response, the quicker we can try and restore some of your normal function and your normal capacity within your system. That will help your body stay ahead of the pathological game. If you leave it too long and the pathological game takes over, now you're going to look for anything and everything that can hopefully help you from pain. So now you're into absolutely the hardest medications you can find and drug therapies that would just help try and break that chronic pain pattern. And we don't want to go down there. You don't need to go down there.
Please correct me if I'm wrong, but pathology is the study of blood.
Or no, so pathology is where your body gets to a state of such disrepair that there's a disease process now in place that is not reversible. It might be manageable, and you might be able to slow that pathological process down to a point that it doesn't keep progressing, but the damage is done. There's a pathology there, there's this disease process that is taken over, and that is now what you had. You're not going to reverse out of that. So now you're looking at ways to try and mediate that, manage it, and try and get some kind of palliative relief. It would absolutely 100% make sense to go to your general practitioner when you've got pain or something doesn't add up, or you're concerned about something in your healthcare. And where I think the sort of transfer between the GP and the chiro, the GP, and is maybe not as smooth or as effective or as efficient as it should be, is the education. There's still a lot of practitioners out there on the medical side, and I'm not pointing fingers at GPs by any stretch of imagination, and the broader sense of the medical practitioner really doesn't know what we do as chiropractors. And so you often find the referrals that we get, and we either got someone who's taken time to go and kind of what we do as chiro, or chiro has actually taken time out to go and speak to a local GP about what they do. Or they've found out from their patients that actually I went to this chiropractor down the road. I don't know what he did. He clipped a couple of things and it's made a world of difference to me. The GP, Craig, can I get his name and details? And in future reference, when a patient comes in with similar sort of symptoms, I go, listen, I don't know what's wrong with you, but there's this guy down the road who's helped a couple of my patients. Why don't you go and try and see if he can help you? And look, that is a great referral anyway, but it's not really how the system should work. Patient presents with headaches, neck pain, any kind of sort of posturally associated thing with that as well. The GP is obviously going to do their assessment, check that there are no major red flags flying out. And then the referral should be, you know what, this looks very much like it's a cervicogenic headache. There's a chiropractor down the road. I've had great results with them, and a number of patients are responding incredibly well. Go and see him, he'll help you sort you out. So 100%, the way the system was designed years and years ago was that the GP is the gatekeeper and the control. And fortunately or unfortunately, with the state of private healthcare in our country, the poor GP gets bypassed very quickly. And because we've got Google and we can ask all the questions, the poor GP gets it in the leg, because why would I go to the GP and there you go to whoever, when actually our private medical system affords us direct access to the next step, the next specialist, the next person you want to see. And it's not ideal, because all of a sudden we, as the general public, we become good at trying to diagnose ourselves, and we preempt what we should be doing or where we should be going next. Whereas the way the system is set up is you actually should be going to the GP, general overview and assessment of what's going on. This needs further investigation, so you go to this specialist or that specialist that contacted on the road, and they would take it further. They're far more specialized in this, and they will fix your problem. That's how the system should work. But as I say, because of private healthcare and the way it's evolved in this country, nobody uses that. There's a few people who still use their GPs, and there's will be excellent GPs out there. But the majority of the general public owners, and also even ourselves for many years in time, I don't think this is a GP issue. I'm going to go straight to the specialist. Now, that's quite good if you guess it right, or Google guessed it right. But what ends up happening is the specialist now is flooded with patients who think they should be there, and they actually probably should. This probably could have got dealt with by the GMD or someone slightly further down the line. Problem comes is now when you need to see the specialist urgently because you've got a diagnosed issue that only a specialist could see you for, you can't get in to see the specialist.
Yeah, some of these guys are booked 2 months in advance.
So again, what's interesting, and there's a lot of historic and political context to this, but where the value add comes with a chiropractor is the fact that they be taught to diagnose and they're called as primary contact in these chiropractors. So in essence, when the GP is full and you can't get in to see the GP or the district nurse or somebody who can do that initial assessment for you, you could go to a chiropractor and have that assessment done. And if it is a chiropractic the issue, you're in the right case. If it's not, that chiropractor will refer you on to the appropriate healthcare practitioner.
Doc, for the patients that you see, is it like 80% sports and 20%, normal moms, dads, corporates, or is it a mix or how?
So, and obviously my passion and my focus and my area of specialization is sports medicine. And so I think by virtue of that, all the majority of the patients I see are very active patients, certainly weekend warriors when it comes to sport, age group athletes, and then sort of your semi-pro and professional athletes. And I would say probably 70 to 75% of my practice is that. And very fortunately, chiropractic lends itself to that population. It just works. It gets them up and firing pretty quickly. They recover from the injuries so much quicker and so much better. And ideally, those patients of mine I've seen for a long period of time, we try and catch them long before they get injured. They already know what the warning signs are, where all of a sudden they're not running as fluidly as they would do normally, or their reach when they're playing a racket sport is not as flexible as it usually is. There's subtle signs that these people are that active will pick up, and they know something's off. So they'll come in, we'll treat them, get them out there before they get to that injury state, which that's where I love to work. Very happy to treat injured athletes and injured patients, but ideally where chiropractic works so well with sports and performance is making sure our athletes don't get to that injury state, is keeping them in a zone where their body's functioning and performing pretty much optimally all the time. The other 25-30% of my patients would be what I would call general practice. So that's your neck pain, headaches, people who've been stuck behind the computer for far too long, for hours and hours and days on end, and your stress-related aches and pains, particularly surrounding the spine. Yeah, I would probably group that as general practice. I don't do pediatrics, and purely because I had a point in my career where I had a choice to either specialize in pediatrics or sports medicine. And obviously my passion is sports medicine, sports chiropractic. I often look back and think I was probably a little bit silly, a bit naive. I probably should have done at least some pediatrics and the sports stuff. But I always see pediatric chiropractic, and it really is a incredibly particular, detailed, specific area of chiropractic. And there's nothing that irks me more than a chiropractor who says they're a pediatric chiropractor who just sees kids. Just because you see kids doesn't make you a pediatric chiropractor. Please make sure if you're taking a child to a chiropractor who reports to be a pediatric chiropractor, they've got the right qualifications. Because to miss a reflex or miss a sign in a child, that's not good enough. If you're purporting to be a pediatric chiropractor, you've got to be on the ball, that kind of stuff. And there's no doubt pediatric chiropractors are amazing. They have the most phenomenal results with those little things. And that's why it's important that you have someone who specialized there. I was never going to give it that time, that dedication. And because of that, I choose not to see kids. I know if it was my kid and I took him to a chiropractor who just kind of sees kids, that was not specialized in it, and they missed something, I would be really upset. So my choice was to follow the sports route. I also felt, it's a bit like anybody who rides horses and is hooked into the equestrian side of it. Like you either resonate with the horse or you don't. And people who ride horses don't understand that. I never really resonated with horses, although I did ride with it when I was a kid. Uh, if you don't get it right, then horse is going to hurt you. They're going to kick you or throw you off. And
On that point, Doc, after over 7.5 years of formal academia, and what was there a significant point in your career that solidified your passion to want to specialize in sports chiropractic, specifically sports medicine? Like, what was there? Was there something that was like, okay, this is where I'm going? Like,
I was always passionate about sports, loved sports, all sports. Always, I was brought up in a very sporting family. And not that I was particularly injury prone as a youngster, but I think probably my exposure to one or two injuries and going through the process of going to see a physio, doing the repair, doing the rehab. I think that's where the fascination came in. And I mean, for as long as I can ever remember, I wanted to be that guy who ran on the field on a Saturday afternoon, treating all these amazing sports stars. Um, and and it was a dream, there's no doubt. As if I knew it too earlier, chiropractic chose me, and I thoroughly believe that. I didn't have a clue what a chiropractic was until after I'd left school and got exposed to chiropractic. But then through my experience with chiropractic and seeing how it resonates with sports injuries and athletes, started to melt the two together. The next hurdle is the fact that chiropractic was still very much sort of that darkness. And certainly when I was still studying, you were very careful about who you told you were a chiropractor.
yeah, well, I mean, at the time, I guess that's what I'm asking. I'm like, and those type of things you're sharing, it's like, why chiropractic?
I came from a very traditional, mainstream, sort of private school background. And the mere fact that I went to Wits Technical to study is already a bit odd. And then literally all my mates were doing medicine, physio at Wits, UCT. So again, all the mainstream background. So when we were socializing, my mates knew what I was doing, knew what I was studying, but anybody outside of that group, you were very cautious about what you told them. And it was often, I work in healthcare. That chiropractic conversation might come out a little bit later when we got to know each other a little bit better. But I mean, this isn't that long ago. This is 30 years ago, 25, 30 years ago. These days, I mean, chiropractic's way more receptive. And certainly you can sit down at a dinner table now and have a conversation about being a chiropractor. Usually the first thing that comes back is, oh, actually, I've got it. Yeah, cool. But I guess that comes with tears, but at least we can have that conversation. 30 years ago, you were very cautious about it, which wasn't great, but it's been fascinating, even in that short period of time, to see the evolution and how chiropractic is more accepted and is being included more and more. Look, we still got a long way to go. We're a very small profession, particularly in this country, but we're growing, we're building, and as I said in previous conversations, there's a lot of history and politics behind the background of chiropractic and chiropractic coming into South Africa. There was actually a law that prohibited chiropractors in this country from accessing the general public. Oh, we weren't allowed to work in public space. We were very much in the private space, and we had no option. We had no choice in it. Now, that law has subsequently been repealed, has been removed from legislature. And so that's been in process for probably the last 15 to 20 years. And the last 5 years, has now been repealed and removed. The problem is that there's a lot of history behind chiropractors being excluded from the public space. So now, even though we are permitted to work in the public space, a lot of the legalities behind it are still very much there. So in terms of being in a public hospital or public clinic, according to their legal documentation and we may or may not still be allowed to go in there. In terms of the greater law, we are, but in terms of the hospital's legislation, they might not have legal cover or an ability to take on a chiropractor. Interestingly, there are public posts for chiropractic within public sector, but again, depending on the hospital and its legislation, its legal requirements, we may or may not be allowed to actually take up the post in that post. But that's all evolving. That's all changing. That's massive change for us in the profession. We are very much involved with the national health story at the moment. We're at the table. We're still in conversation, which is great for us. And look, if and when the time comes, when you put the NHR together, the chiropractic is still at the table. Our biggest issue is going to be, can we fulfill those posts? Because as I say, we're a very smart profession. The fascinating thing is that the largest percentage of our population are manual laborers. And one of the biggest issues we have from a socioeconomic perspective is that a lot of these guys that got tunnel work or not able to work or mechanical work there.
Now, she is a chiropractor can say
is that's not really bad. That's what we do. And I mean, we try to rely on statistics and data, which we unfortunately don't have in this country, but we draw that data from the US, from Australia, from Europe, which don't necessarily have that manual labor base that we have. But the data is profound. The amount of mechanical load that came from the number of hours of work that are lost, and the cost of that to industry is huge. And yet we're not utilizing chiropractors in this country to assist with that. And the amount of money we could save something like the NHS or a public health system is profound.
So how would you, if you wanted to get into that, I mean, are there organizations or, I mean, that's another question I would ask you, is that you were a lecturer at UJ University for many years with chiropractic. So tell me, like, share some insights, like how did you do it for? What?
And so when I got back from the UK, obviously I was trying to get some momentum going and just open up my practice. And to kind of fill the hours and keep me busy, I applied for a lecturing post at University of Johannesburg. And I ended up lecturing there for 10 years. I was lecturing the 5th year master students in clinical chiropractic, which I absolutely loved. And I still get invited back occasionally for the odd guest lecture, which again, I thoroughly enjoy doing. I thoroughly enjoy engaging and interacting with the students, and at least trying to give them something more to think about. It's to think outside of the box and from what they get taught within the institution. I'm still very involved in the Chiropractic Association of South Africa. I served 2 terms as president on that association. And when it comes to NHI and dealing with the Department of Health and where chiropractic sits in terms of the health landscape of this country, the Chiropractic Association of South Africa is our unclean bearer. And they're at the rock face. They're having the negotiations, discussions with the Department of Health. They've also recently developed a mentorship program. So I'm very passionate about that and be very involved with that over the past year or two, and helping mentor new graduates into private practice. Because there's no doubt, I mean, you come out of the institution, you think you're ready to rock and roll, you've got this toolbox, and yet the transition from being a student practitioner to running your own practice or being in the big wide world as a practitioner is meteoric.
It's like when you come out of a trick, you think,
It's like,
so it's so all those years, a decade of lecturing master students chiropractic, and how do you transfer that knowledge, wisdom, passion into your practice? How have you found that help you in what you do today?
yeah, I guess that exposure and the first to try and help educate those young practitioners, those new chiropractors, to help them, I guess, experience some of the thrill and the enjoyment that I get out of chiropractic, just fuels you with all. And it certainly, it gives me energy and it helps me in practice. And but also the fact that you're giving back and you're helping grow the profession, and hopefully igniting a passion in these younger chiropractors to at least go down a similar path to where I went down. Um, as I said, a chiropractor chose me, and in my short career, 25 odd years,
Sure, and yeah,
it literally feels like a blink of an eye. And I've been incredibly blessed. And I've been incredibly fortunate to be in the positions that I've been in, to experience and the different avenues that I've gone down within the profession, both within this country and abroad, and the opportunities that I've had, and as I say, the experiences that I've been afforded from being within the profession. I could never have guessed 25, 30 years ago. And and I really would love for the younger chiropractors that are graduating and coming out now to even experience a fraction of that. I do think that it goes back to some of the old adages about you get out what you put in. And then there's no doubt I was completely committed, and passionately so. And I think
when you said that, so are you like, up 4 or 5 in the morning studying for 12 hours? I mean, were you highly disciplined as a student right through? I mean, to this day, you mentioned you're up at 4, training, working on hours.
I certainly got given a big wake-up call when I was transitioning from third year to fourth year, which brought to senior years.
Why is that?
And because I think I thought I could coast. I was playing a lot of sports, and I was playing a lot of potential, and under 21 popular at the time, and that seemed to be my focus more than my studies. And bizarrely ended up faltering on probably the most innocuous subjects in third year. But if you didn't have it, you weren't going to fourth year. And the head of the course at the time actually called me in and sat me down. He said, "You're in a lot of trouble, Barry." He said, "You've failed the subject." And he said, "Because of that, you're not going to third year." He said, "I bet out the backwards to accommodate you here with your hockey, so you could go on these hockey tours or playing the 21s of French or more rest of it." And he said, "You've let me down." He says, I'm not sure I can help you here." And dismissed me from his office about your tutors. That's the done.
Okay, so that was the wake.
I don't go home now and say, "Sure, X, Y, actually, I've just been dismissed from the chiropractic course." No, what I do. And about, he obviously let me stew for a little bit. About an hour later, he phoned me. He said, "You're still on campus?" So I said, "I am." He said, "Come back up to my office immediately." So I ran up to his office, went in there, and there was a practitioner who was part-time lecturer who was sitting there at a meeting with him. And I walked into his office. I said, "Well, I apologize. I didn't realize you was the doctor. I'll wait outside." He said, No, stand there." And he stripped me off in front of this other doctor, which is obviously highly embarrassing. And he said, "You've got one opportunity. I'll let you write the final exam. If you don't come out with a pass mark of 80%, he says, that's it. Our agreement's done." So he threw me a lifeline. And I think from that point onwards, I realized, listen, if this is where you're going to go, you better knuckle down and do some work. I still wouldn't say I was the most overly diligent student, but I obviously then pulled my figure out and did some work in my senior years.
80%, huh?
Listen, he wasn't, I upset him, which was understandable. So I managed to get over that hurdle. And then I got my head down for my senior goals, and so much so that I really pushed hard to try and finish my research and the dissertation as soon as possible. And then there were 2 of us from our year who actually graduated at the end of our 6th year. We started off with a class of 50. And I think out of that class of 50, there were about 14 or 15 of us who actually completed the year. And there were only 2 of us who finished at being in our 6th year. But I mean, for me, that was critical, because the minute you got that done, at least you could get out there and then start practicing. And it wasn't long after that I did a couple of locum jobs locally, and then I went to the UK. And that was largely to do the postgraduate kind of internship, which they afforded us. That is under sort of grandfather clause. And the idea was to go and do that and then come straight back and start practicing in South Africa. But I think being exposed to everything that was available in Europe, and the top lecturers from around the world are passing through Europe all the time, different courses, different techniques, different approaches to musculoskeletal healthcare. And I was like a kid in a candy store. So literally every weekend for the first 2 years I was there, I was on a course learning something new, different technique, a different approach, whatever it was. And I think that really ignited my passion for chiropractic and obviously filled my toolbox up with a gazillion and one different approaches to how do you treat your patient. And 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 I guess in the back of my mind there was always this yearning to get back involved in sports, to do sports chiropractic, to do sports medicine. Obviously, at that stage, sports chiropractic was a lot more accessible than sports medicine. In fact, sports medicine as a chiropractor was almost inaccessible. So I did a lot of the sports chiropractic postgraduate qualifications, started to build up on that, started to work for sports teams, and worked for the British Masters Athletics Federation for 5 years while I was there, and traveled with the team to all the European and World Indoor and Outdoor Championships for 5 years.
You traveled with them for 5 years. Tell us about that. What was that?
Listen, amazing experience. And obviously it was a selected team for those events. So it wasn't like you're on the road on a day by day basis for the year. And you would have indoor would be kind of February, March time, and then outdoor would be July, August time. And they would alternate European and World Championship events. So the one year would be World Indoor and European Outdoor. The next year would be European Indoor and World Outdoor Chase. But yeah, I'd get to travel somewhere different in Europe or around the world. So it was athletics, so track and field. And that really was a strong base for me for 5 years when I was in the UK. But got involved with treating rowing, triathlon, rugby, hockey, cricket. Got involved with Derbyshire County Cricket and a little bit of work for the English Cricket Board. By virtue of studying my sports medicine at Nottingham University, was afforded a little bit of insight into UK athletics, UK triathlon, swimming now and again, and then, as I said, the English Cricket Board. So a lot of that stuff fueled my sports desires, and some great exposure with some elite sports and elite heads in those sports. Consistently involved with the university sports, whether I was in Cardiff or Nottingham. I got involved with the university sports. So it's a really good and broad exposure to a lot of different athletes. Then got the opportunity to study sports medicine at Nottingham University. The master's sports medicine and sports and exercise medicine course there was one of two in the world at the time that would take on allied health professionals. So most of the sports and exercise medicine courses around the world and on programs are designed for medics only. And some extended it to physiotherapists, but that was about the limit. And Nottingham, and I think there was a course in Sydney that would open it more broadly to the allied health professions. So that's fortunately how I got into Nottingham.
When you say sports medicine, would you care to elaborate on that? Are we talking as in medicine for athletes? As in, so, because that now we're entering kind of GP world.
Yeah. So you find a lot of your GPs have a special interest in sport, would do a master's in sports and exercise medicine. So the majority of sports positions, they would have done that qualification. So in essence, they would have a super specialized GP who has a very strong interest in sports and exercise medicine. Interestingly enough, it's not recognized as a specialization at the moment. There is an ongoing debate and there's an ongoing process to try and get sports medicine recognized as a specialization, but at the moment it's a special interest. But there is that qualification, a master's degree in sports and exercise medicine, and your sports physicians will have that qualification. Now, the interesting thing about bringing the allied health professions into that environment is obviously your GPs and the special interest in sports medicine come from a very medical background. And so would look at possibly the pathological side, what's going on with your cardiac system, your respiratory system, and the impact that might have on your performance as an athlete, and how they can help you not only train more effectively and efficiently, but how you can maximize your performance, even though you might have some kind of disturbance or pathology associated with your heart or your lungs or any other system in your body. And so they would come into that course with that background and that knowledge, but often lacked the musculoskeletal side of the athlete's healthcare performance. So that for them was a whole new world. They learned a hell of a lot of stuff in terms of musculoskeletal medicine, but bringing that in with their medical knowledge gave them a good rounded approach to treat work and off the athletes. Coming from an allied health professions or an allied health care perspective, was the complete reverse. So we had a really good, strong knowledge and base on musculoskeletal health and the approach to managing that in your athlete, but very often lacked the knowledge in terms of pathology and performance when it came to the cardiac system, respiratory system, and any other system that might be associated with that athlete, or promise that they might have those systems associated with that athlete. So that was our broad scope and stuff that we needed to learn and understand to be able to work as a sports physician. So it's fascinating getting those two opposite poles coming together and learning the same material. I mean, obviously for the medics, the medical side of stuff was easy. They'd done a million and more times. There were nuances in terms of an athlete, but by and large, they had that stuff down packed. Then they had some normal musculoskeletal stuff. We had a good sound knowledge of the musculoskeletal stuff, but obviously had a lot to learn in terms of the medical side of things. But what was quite nice is that rubbing shoulders with people from those different backgrounds, you understood people's strengths and weaknesses. And going forward from there, having that kind of network, when you were dealing with an athlete as a sports physician, if it wasn't your area of super specialization, you go, actually, there's a sports physician down the road who's absolutely specialized in the cardiac side of things. He's going to see they will help us with this. So that for me was unbelievably fascinating, and that really fueled my interest and my thirst in terms of sports meds. Well, I'm always going to be a sports chiropractor. I'm always going to default to the musculoskeletal side of things. That's my passion, and that's where my super special interest is. But having the knowledge of that other stuff is so important and critical when you are dealing with athletes. And then also knowing who you refer to within that network has been hugely advantageous and hugely beneficial in my practice.
So that beautiful wide macro view coming laser focused to where you're at now. There's two practices. We currently, there's the Morningside Chiropractic Sports Injury Center, and you also based at the one where we are today, the Wanderers Sports Center. So, Doc, tell us specifically what services you offer. Is it the same services at both practices, or?
So they're similar. I ended up at the Morningside Chiropractic and Sports Medicine Center, is within a private gym facility. We have a resident biokineticist, and we got sports massagers, the massage therapists. We're very closely with the trainers within the gym. So that covers a lot of the rehab and the reconditioning, that strengthening side of what we're doing with our athletes and our patients. And then obviously the sports chiropractic side of things. So we run the general practice as well as the sports injury and sports performance side of the management of our patients and athletes. Within the services we offer as the chiropractors, we make quite good use of a lot of laser therapy, or what they call low intensity light therapy, and which certainly across Europe and North America is booming at the moment. There's an opioid pandemic going on, which is second to none. It is very prevalent in this country, although we're not acknowledging it as much, but it's getting to the point where something drastic needs to happen. And basically what's happened is people with chronic pain rely very heavily on these opioids, which are painkillers, and they've become addicted to those. So it's got to the point now, especially in North America and Europe, that you can't prescribe opioids to the patients with it. So we're desperately trying to find mechanisms to help these patients deal with their pain, the chronic pains.
And this laser therapy you mentioned is,
So light therapy has been around for that's a spirit, and it's using different wavelengths of light to initiate certain chemical processes within a cell to try and get a cell to start healing, performing, and doing what it does best. And the theory is that these days we may actually cut ourselves off from a lot of natural light. We're under fluorescent light most of the time. We're indoors. If we do go outdoors, we cover ourselves in factor 50, or we wear
With your own sun, it's about this.
we wear sun protection clothing, which
But that's a good thing, isn't it?
in principle saves us or protects us from the harmful rays, but it also blocks the natural sunlight from coming into our bodies. So one of the principles or theories behind what's happening these days is that because we're not getting natural light into our bodies, our cells are not picking up that natural light and are not kicking off those natural processes that allow our cells to stay healthy. So we're now more prone to lifestyle diseases. We don't heal as quickly. We don't respond as quickly as we should do. And we've been encouraged to now go out and spend 20 minutes a day under the sunlight just to try and get vitamin D into our systems and try and trigger off some of the natural processes that keep our bodies healthy. So this is where this low intensity light therapy, or what they call photobiomodulation, seems to be having a really good effect. And not only from a healing perspective, so with your injuries, but with your mild to moderate chronic and mild to moderate inflammatory conditions, but also your chronic injuries and chronic acatics as well. And depending on what you deal with, we can treat the wavelength to target that tissue and target those chemical responses to start getting a healing effect back into that tissue. As I say, the results that are coming out in the research from North America and Europe are significant.
Well, how long have you been using this therapy?
So we've been using photobiomodulation for probably about photobiomodulation.
Yup.
It's quite a word, isn't it? It's quite fancy. Is in essence, it's no TC light, but
Okay. How long have you been?
in our wondrous practice for about 8 years now. And that runs independently. And as chiropractors, if there's an acute injury or this chronic pain syndrome that we do, we will funnel them onto the laser therapy machine in order to help with the healing process. And as I said, that runs independently through our Sandsman Laser Therapy Center, which is housed within our chiropractic facility at the Warrick Sports Medicine Center. Moorside Chiropractic Sports Medicine Center, we've got a handheld laser machine, which then we'd integrate that into the chiropractic treatment while they're there at the same time. As I said, it depends on what they're presenting us, which will dictate what the settings are on their handheld machine. And the settings will dictate the depth of that light, the intensity of the light, whether we use pulsed or consistent light, and then the color of light that we use as well. And it also dictates the kind of response that we want to get out of the tissue. But in essence, the idea is to initiate certain chemical responses within the cell, so we get the cells started to function up, we get help with the healing process and renew the inflammatory side of things. At the Wondrous Sports Medicine Center, we have a far more comprehensive and diverse setup. There are a number of physiotherapists, biokineticists, massage therapists, there's a dietitian, there's an optometrist, there's a sports physician, there's a dentist, there's a homeopath, there's a sports psychologist. And we're there as the chiropractors. As I said, we run the photobiomodulation or the laser machine from there. There's hyperbaric oxygen. There's, what else? We've got real orthotist. We've got an orthotist as well. And although we all operate independently, we do operate under the umbrella of this Wonder Sports Medicine Center. And it really is a diverse and very comprehensive healthcare facility. We also have the contract with the Lions Cricket. And so our physios are directly contracted with the Lions. So we see a lot of the Lions cricketers coming through. And they obviously have access to all of these wonderful facilities within this Wonder Sports Medicine Center.
Doc, take us through the first, when a patient first comes and sees you, the journey of when they're injured to recovery. What does it look like? What's the process?
So obviously they would initially book to come in and see us. And depending when they come to the Wondrous Sports Medicine Center, or they come to us, see us in Parkmore at Moorside Chiropractic Sports Injury Center. And when they first book and engage with us, they'll receive an email confirming their booking, and on there is our import consent forms, etc., which we encourage them to complete before they arrive. And so when they arrive, They get met at reception, and they just need to fill in a form with a few more details, and then we will meet them as the practitioner at reception, take them through to our practice room, um, and initially we'll sit down and we'll have a chat. So we first want to understand what is a presenting complaint, what's the background behind it, what sort of pain are you dealing with, when do you get the pain, how is it impacting your life, and just try and get a good broad sense of kind of where they're coming from, how long they've had the issue, and probably most importantly, and particularly when we're dealing with the sports side of things, is the mechanism behind how they got injured or where they got to a pain syndrome. That often gives us a lot of clues as to what we might be dealing with and maybe how we need to approach the treatment behind what is going on. And to say that I was playing in a game, I tore my hamstring is great. How did it happen? Were you on your own sprinting for a ball? Were you involved in a contact situation, and next thing you twisted and turned and your hamstring went? All that kind of detail is quite important
Also interesting, Aaron.
in terms of potentially how you got injured, what tissues may or may not be involved, mainly what joints may or may not be involved if there's a tissue injury. But if we mean at that background knowledge, we're already starting to think, where are we going with this? What could be involved behind the actual injury? And it's not simply just the hamstring injury. So generally, by the time we finished with that initial consultation, where we go into their general health, their family history of illnesses and diseases. And it's quite interesting. Often when we get asked that question, they go, no joint or muscle pain. We're not asking that question. We need to know, is there a history of heart disease, no disease, cancers, diabetes, those kind of things, because they all may well have an effect or a background behind how you got to where you got to, or may have impact on why you have a pain syndrome, or how we can approach the treatment of that. Somebody with diabetes, and the approach to how we manage their back pain or leg pain is very different to somebody who doesn't have diabetes or a history of diabetes in the family. So those sort of questions are really important to. And again, start putting the pieces of the puzzle together for us. We'll go into a detailed medical history, whether they're taking any medications, supplements, multivitamins, those kind of things, previous injuries, surgeries. So we get a good, thorough, all-round overview of what's going on with this patient, not just the particular pain that they're presenting with that day. We go into a little bit of the dietary history, and we'll also go to the exercise protocols or the exercise regimes, whether they are exercising at the moment, whether it be previously, what does a general week look like in terms of their exercises and the intensities of that. So once you've got that broad picture, ideally you should have about a 60, 70, 80% is sort of idea of exactly what you're dealing with this patient before you've even taken it any further. So the next phase is to get them up out of a chair and to start examining them. So we'll do a full thorough movement examination to see what their ranges of movement are like, where they're being restricted, what's painful, what's not painful, and also for them to particularly identify where their pain is. From there, we will take them into a full peripheral neurological assessment and an orthopedic assessment. As I said, by now, we are honing in on where this potentially is coming from and on what we need to be dealing with. So within that assessment, we try and isolate or refine it to the pertinent state that is now going to give us a differential diagnosis. At the end of those examinations, we should be able to say to them, right, this is your differential diagnosis. And ideally, we want to come up with 3 or 4 potential diagnoses that are all regulate. The hunch will be on one particular diagnosis. However, you may want to back this up because you don't have all the detail at that point of time with a couple of differentials behind that. If at this point you've picked up a number of red flags and it's contraindicated that you go forward with the treatment, you may want to do special investigations. You may want to refer them for an X-ray, an ultrasound, an MRI scan, CT scan, bloods, whatever other special examinations may want to find. You may also at this point want to actually refer them to a specialist who's a specialist in cardiology or is a specialist in rheumatology or whatever, where those red flags might have shown up. Barring those red flags or any reason why you should be able to continue with the chiropractic assessment, the chiropractic treatment, you would then take the forward into that. The treatment itself, which we would try and incorporate within that initial engagement, initial consultation, and assessment, would go through explaining to the patient exactly what is going on, what we found, explain the injury, and what we need to do in terms of a treatment protocol going forward. So to try and give them an idea, is this a 1 and 2 treatment scenario? Or actually we're looking at 6 treatments over the next 3 to 4 weeks. This is the expectation of how we would expect you to proceed. At the end of that, we now need to incorporate the biokineticist, maybe a bit of physio or a massage to help us with a little soft tissue work. The biokineticist is now going to come in and help you with the end phase of rehab and then strength and conditioning going forward. So that's where we like to pull in the resources that we have both at the Wanderers Sports Medicine Center and it's our Morningside practice. You may want to bring in a dietitian to help with some of the dietary scenarios, help with controlling some of the inflammatory conditions that are going on with the body at that time. So by the time you finish that first treatment, that initial assessment and your first consultation, you've got a pretty solid idea, and certainly your patient's got a pretty solid idea of where they've come from, what the injury is, how it came about, and how we're going to deal with this.
Which is incredibly detailed, Doc.
Absolutely. And we spend between 40 minutes and an hour with a new patient, and it's jam-packed. And there's a lot of detail. There's a lot of feedback that comes back to the patient. Without getting too engrossed and incorporated in that feedback and trying to explain to that patient exactly what's going on, the one thing I always find is really, really important is trying to find out from the patient what their expectations. As a practitioner who's passionate about getting you back out there fit and healthy and performing, that's where we go. But that might not be your goal, and that might not be your ambition as a patient, as bizarre as that sounds. They might just want to get enough other pain that they can get back to doing what they're doing in their everyday mode. And you often see that. Patients will come in with headaches, neck pain, and it's all stress and posture related. 1 or 2 treatments, they feel a lot better. They're not perfect. They're probably 60% better, and they're gone. They're despair. All they needed was that respite to get out of the heavy cloud that they were under every day. They'll be back at some point when it gets to that stage again. But for now, all they needed was just to get out of that zone to get them going again. And that's fair enough. And that's what the patient is there for. That's their expectation. And as long as you as a practitioner understand that, you can both be on the same page. If I'm trying to make you perfect and actually you just want to be able to pay, we're not going to see eye to eye here, because I'm going to be quite ambitious to get you through that process, of get you out to the bike and notice the strength and then your conditioning, and actually you just want 1 or 2 treatments, get out of your pain, and I'll see you in 6 months. I'm happy with that. But again, as long as you've had that conversation and you both understand the expectations and what the goals are, everybody's happy.
Doc, understandably, you mentioned 75% of your patients are the cricketers, the sports athletes per se. That 25%, do you find that people that don't do exercise at all generally have these like symptoms? Because I mean, 75% of your patients being athletes, I mean, they generally eat well, sleeping, they're exercising daily, so they perhaps don't tend to have much headaches. Versus is that a wrong assumption to make? Or, I mean, because athletes, I'm sure, do get headaches. So
I mean, it's a fascinating conversation, and it's a fascinating point that you raise. I would say that the simplest answer to that is moderation. Not that any of us know what that means, but you've got those who are active, and in this country in particular, we tend to be very active. If we're active, we do a lot. So we often have aches and pains from our training and from the activities that we're engaging with. And largely because I think we all like to think that we're still professional athletes from when we were at school and the university, and we still play at that level, but yet we've got a full-time job and other lives. We don't worry, as you say. We like to think we're still playing at that level, but we said, you're not doing the background stuff that affords us to do that. And we're getting a little bit older. Not that that's any excuse. So I do think we've got on the one side a population would do a lot of exercise and probably too much. And then we got on the other side, we've got a population who don't do anything. And I would say by and large, this population that don't do anything probably experience less pain and discomfort than this population here. But your health is your investment. So as you're trickling through your 20s, 30s, 40s, even into your 50s, you may well have aches and pains in this column because you do too much exercise. But the investment you've got in your health, because inevitably you're eating better, you're not over consuming alcohol, you're generally not taking drugs and smoking and all the things that we know are bad for us. You're generally looking after yourself quite well, even though you're getting the odd ache and pain. That, as you go into your later years, is going to stand you in far better stead than somebody who's had no aches and pains for 30 years, been completely sedentary, done absolutely nothing, never had an apron hell in their eyes. By the time they get to their 60s and 70s, all of a sudden, their heart is not great. They've got issues with their lungs. Arthritis has crept in regardless of whether they've done sport or not. And now all of a sudden, now they need to change their complete lifestyle and try and become active, try and eat healthily, try and start taking care of themselves, which is pretty far.
Would you say there's a specific age generation gap that you picked it up, what you've just mentioned? But that start.
So you will tend to find those sort of people probably from 50 onwards, and probably demonstrably more mid to late 50s into their 60s. You'll start to see these sort of people. They might even get away with it into their mid 60s, but all of a sudden, by the time they're late 60s, 70s, these are the people with chronic lifestyle issues. And now they're on lots of medication. They really can't do things. They can't go for a walk. They can't go do exercise because their system is busy shutting down. And they're in a diseased state. They're not pathological. So I come back to the original term, moderation. And that can mean a million one things for you, can mean a million one things for me. But I think it's important that you're moving and you're keeping your mind active. Those are probably the two biggest things in our lives. As long as you keep your mind active and you keep moving, you're actually not going to be too far off the mark. As I say, I think generally as a population, we do a lot of exercise. I don't think that's a bad thing, might be a stretch of imagination. We could probably tone it down a bit. We tend to do things in the extreme. You know, most places in the world, if you run a marathon, you are a phenomenal athlete.
If you ran
For a couple. You are a phenomenal athlete. But in this country, and I always joke about this, you go to a dinner party and they say, so what do you do? You say, I'm a runner. They go, oh, wow. How many comrades have you done? And you go, well, I say, I haven't run comrades now. End of the You might have run 20 marathons. You might have run comrades. I haven't. The pressure is on. 42 Hoffman. My dad ran 11 of them. So I grew up on my dad ran 20 of them. So I grew up on the side of the road, watching my dad run on race at Two Oceans. And I've run Two Oceans Lapit, probably the best race, I think, in the world. There's a look history. So, yeah, and I probably haven't run as many marathons as I probably should have, but I've run enough. I've done a couple of Ironman as well. So, I've got the experience there. But the fascination for me is this, the extreme activity that we do in this country. The Doozy Canoe Marathon is a 3-day event, but now we're going to do the 24-hour Doozy. Or there's guys now.
So pushing your body to limits like that isn't necessarily a bad thing. I mean, so obviously you can't do it every day, but I mean, you doing it yourself. I mean, you're pushing your body to extreme.
That's the challenge. And I think a lot of the stuff becomes a mental exercise. It's not a physical or fitness exercise. It's very much a mental exercise. I mean, these 100-mile trail runs, the number, actually just take comrades. Comrades are a great example. I recommend shooting a number off the top of my head. the number of people who are genetically adapt or physically adapt to run comrades, I doubt is more than about 5 or 6% of people who line up on at the start yard for comrades. They physically and genetically are able to cope with running 90 kilometers. The rest of the people who line up, and they could run some magnificent times. They could be running 6 hours, sub 6 hours for comrades.
It's very good, but sure.
Are running on a women prep. They've pushed themselves so that they obviously had some genetic capacity and capability. There's no doubt about that. Is their body designed to be doing that? I would say is a film no. And with that comes all the degeneration, the breakdown, and all the negative side of exercise that you hear, because their bodies aren't designed to do it. That's not to say they're not athletic. There's a million and one other sporting activities they could do. It's just the absolute extreme of taking the body and hammering it for 6 hours, 8 hours, 12 hours, when it's not genetically designed to do that. So that becomes a mental process, and then you achieve it. There's no doubt it's massive gene. And it'd be interesting, and I think there are correlations and studies out there, that I think because of the stress that we're under in this country, on so many different levels, we default to these sort of events to help us cope. It's our escape. It's our way of actually coping with life, keeping our stress levels moderate. But it's extreme. It's extreme. There's not many other places in the world that draw these kind of numbers to these sort of extreme events. So you're very unique in that regard.
I mean, you've worked with world-class sports athletes. Are there swim types or body types that you think, okay, that is an athlete, that is a tennis player, that, I mean, is there a thing like that? Yeah, I mean, that looks like, that is a runner. Yeah?
There's certainly
So you can't,
there's certainly body types that certainly suit certain sports and certain versions of the sports. I mean, you're not going to take a traditional 100-meter sprinter with rippling muscles and expect them to go and run a 5.5-hour conference. Whereas you take a typical lean bean javelin type body, and they're more likely to succeed at comrades than your massive bone sprinter.
okay, look, I can understand that. I was just at the correlation between body types and sports. Now, I'm not, everyone has their own preferences. I mean, some people want to run or jump or whatever, but now there's got,
It's actually quite fascinating because the way when you break down your genetic makeup, within your genetic makeup, you could very much have a predominance of strength genes versus maybe endurance genes. So interestingly, you somehow know how your body responds to certain activities on certain sports. And by virtue of that, you will gravitate towards those sports because you get a good feeling, you're good at it, you get a good response out of your body for it. So inadvertently, you end up doing what's appropriate for you and your body. But often there's an interesting mix between, say, the strength and the endurance genes. And you might get away with doing a strength sport as an endurance athlete and vice versa. But if you get that genetic breakdown done, and you can actually see in black and white, you may then be able to play to your strengths. And your training in that can be more directed towards your endurance genes versus your strength genes, for example.
you mean actually looking at blood, gene, DNA, you can say what sport you're going to be better at.
100%. How else? There's a number of companies around the world also that do it. When I say a number, there's probably a handful. And one of them is based in this country. Is one of the world leads in looking at your genetic breakdown, and being able to explain to you how your body and how your system works. And the one thing that a lot of patients ask me for is the sports breakdown of that DNA assessed. And it does, it very clearly gives you an indication of where your strengths lie in terms of whether you're more of a strength athlete, speed athlete, endurance athlete, and then how you should be training. Are you the type of, are you genetically more adept to training 7 days a week, high intensity, heavy loads, or actually, in terms of your genetics, you should only be training 3 times a week. And 2 of those should be really light sessions and what you can push as a strength session. You might stumble upon that per chance because the way you current your body and how it feels. The likelihood of you getting it spot on is probably not right. So something like this, which gives you the breakdown, helps you focus and hone in on what your training should look like, what your recovery should look like, and ultimately how your performance is going to improve.
So your triathletes, your cricketers, your rugby guys, your soccer guys that you see, do you actually advise them? Listen, like, are you training today, or this week take it easy, or 2 weeks take it easy, then a third week push? Like,
So a lot of more the elite athletes are really tapped into a coach, personal trainer who manages a lot of that stuff. So I try and engage with them, and we try and swap information as we're going along, obviously for the benefit of the athlete or the patient. Anyone who's at that sort of level anyway, at that elite sort of level, is probably already into a high performance center and has access to a lot of these people. So, I mean, a lot of my knowledge comes from having done my sports and qualification, and my impression.
done it for so many years, yeah.
But I will work with the coach and whoever that is, whether they've got a sports physician who oversees them, whether it's a physio, whether it's a biokineticist, whether it is a personal trainer, or trying to work together as a team to obviously get the best result from that.
Tell us generally, what common injuries, sports injuries, treatments do you commonly treat within your practice?
So I'd say obviously being a chiropractor, the sort of tendency is more towards back injuries. Unfortunately, working at the Wonder Sports Medicine Centre now access to the Lions cricket and work a lot with their fast bowlers. And obviously, a lot of stress and strain in fast bowling. And typically, one of their most common injury packages is low back pain. The one thing that we do get a bit nervous about, we need to keep the strain eye on is whether we're responding lysis or responding anesthesis, where you get a bit of a stress response in the bone right at the bottom of the spine, usually in the last lumbar vertebra. And with the workloads these bowlers are under, it's critical that we keep an eye on that workload and we make sure that mechanically they're as sound as possible. So even with the added workload, we're not completely hibernating the tissue to the point of failure and then injury. And so I'd say, well, we see quite a few cricketers in that same sort of realm, similar sort of injuries, similar sort of presentations are your dancers and your gymnasts, all that sort of. What sort of dancing? Like generally any kind of dancing, but anything that involves hyperextension or further extension to the back leaves these athletes prone to stress responses at the base of the spine. So they kind of all fall into the same category. Divers as well, in terms of springboard diving, platform diving, that kind of stuff. So we see a lot of that. In terms of kind of neck pain and upper back pain, you're looking at just cyclists, mountain bikers, road cyclists, triathletes, and swimmers as well. You get a lot of that. Golfers, a lot of back. I'm maybe some golfers, but as I say, as a chiropractor, we have a large percentage of back related stuff that comes through. But on top of that, being more sports medicine orientated, and we get our soft tissue injuries, your hamstring tears and pulls, biceps, quads, calves, kidneys, all of that stuff. What is probably more pertinent when it comes to dealing with those sort of injuries and the athletes that present with that is our approach. Yes, you've got a soft tissue injury. You may well have a grade 1, 2, or 3 tear in that soft tissue. That's great, but how did it happen? How did it get there? Um, I always say as an elite athlete who trains 5, 6, 7 days a week and on the track, as I say, a sprinter, for example, your body is so finely tuned and you're doing everything to make sure that it's so finely tuned. How randomly in one training session or during a race do you end up tearing your hamstring? What's changed? Why would you all of a sudden tear a muscle that has been highly conditioned for a long period of time out of the league? So we need to get to the bottom of why. all of a sudden this muscle is tall. And it's not good enough to say, oh, it's tall because you're running fast. That's what you do. You're an elite professional who's super trained at doing it. So what has changed? So what can change is either the signal that's coming from the brain to tell that muscle what to do has changed somehow, or is a miscommunication there. So the brain's telling that muscle what to do, but what's actually coming out the other end in the actual muscle is different from what the brain thinks you do. That discrepancy can certainly cause a tear, spasm, or reaction in that muscle. Has the origin and insertion of that muscle changed? So where that muscle attaches onto one bone and onto another bone, either side of a joint, has the joint changed to change the load and the tension on that muscle? Has the joint locked up or become restricted? For one reason or next, if the joint moved in a position now that it's again changed the tension on that muscle, what is altered that has caused that muscle to fail? Now you can get in there and you can treat that muscle. And I can always remember going to listen to the head physio of UK Athletics at the stage at a British Sports and Medicine conference. And he was being put under the grill in terms of treatment of hamstrings, both in the athletes for UK Athletics, but also professional Premier League footballers. And he was putting out a lot of very interesting research. And he said at the time, he said, we've looked at this from a million and one different angles. We've tried all sorts of different treatment techniques, and I think we're getting to a point now where we've gone from taking this from a week down to 7 days. And in that lies the nuance. It doesn't matter how you deal with a muscle injury, it's going to take 7 to 10 days to get this thing fixed. And there are clinically guided protocols that you can follow. It doesn't matter if you're a physio, a biologist, sports massage therapist, a chiropractor, you follow that protocol, that muscle tissue is going to heal. Are we dealing with what caused the problem? And that's the crux of the issue. So unless you go and you look at the mechanics, the alignment, the joint mechanics behind where that muscle originates and inserts, the neurological input to that muscle tissue. And unless that stuff is being corrected, the likelihood is that the athlete's going to tear their hamstring again, because you actually haven't changed anything other than you just heal the tissue. You haven't addressed where the problems come from. And I think that approach, certainly from a sports chiropractic perspective, makes a massive difference in terms of not just the recovery, but the likelihood of re-injuring and then reproducing top-end performances. And so in terms of what we see commonly, I would say there's a strong lean towards back pain, generally mechanical stuff, but could well be a neurological background to it. So it could be a mild disc relation, and there could be some disturbance on the peripheral nervous system that's created the injury. And that, I would say, is probably our bread and butter. But the mere fact that we work in a sports injury environment, we will see soft tissue injuries, ligament injuries, those guys there.
Doc, you mentioned that 7 days scenario where it takes 7 to 10 days to heal. The first thing that came to mind is that if one has an injury, whether it's sport related and work or what have you, like I'm sure there are people that kind of will just lie in bed for a week, 2 weeks, 2 weeks, and let it heal naturally. So are there specific perhaps injuries or things that happen? I guess my first question, but I think, and you beautifully mentioned in a quote, the body has a miraculous way of healing. So your specific service you provide, I guess, talk us through that healing period. In other words, if you had, I suppose that depends on what injury you have.
So that I've been largely, and very, very traditionally and historically, if you went to your GP or you went to a doctor, and actually, even if you'd gone to an orthopedic surgeon, those that probably a neurosurgeon as well, one of the things would have been, you're not a surgical case, here's some painkillers, go home and rest. And that was the advice. And for ever and a day, and certainly our grandparents grew up in that environment where go to bed and rest. Now, that's probably the worst we could do. To be fair, Given enough time, your body will work around the issue and you will start to get rid of the inflammation and it will start to heal. That could be 2 weeks, that could be a month, that could be 6 weeks down the line. It depends how in touch your body is with what's going on and how ready it is to help repair itself. And the pain is to take pain away, but you've been given enforced grace to try and give the stimulants to calm down, settle down. Kind of makes logical sense. What we're learning, and we have learned a lot, is the sooner you can get mobile, the sooner you can get back to function, the quicker you're gonna be ill. And so, in as much as pain is your alarm system, and your body's way to say, I'm not happy, don't abuse that. We need to be in a comfort zone, and we need to be in a space where we're not aggravating that tissue. So we were talking about hamstrings earlier on. What we've now learned is that when you get a hamstring tear, the hamstring's a big muscle, a huge muscle, and you might have a little tear in the bottom third of it. Why would you shut off a whole muscle for a little tear in the bottom third of it? So what they've now started to do is, while we're treating the tear in that bottom third, why aren't you using the top 2/3 in the bottom in the fifth or whatever? As long as you're not working in that painful zone, there's nothing wrong with the rest of the hamstring. So you can be doing exercises, squats, lunges, leg curls, whatever you need to do to keep that muscle activated, as long as you don't work in the zone where that tissue is damaged. Now, that keeps the muscle firing properly, keeps it healthy, and speeds up the rate at which that tear starts to heal. So similarly, in terms of what's happening with any kind of back presentation, you got a sore back, you've got an acute flare-up of a joint in your back. The first thing we want to try to do is get function back into that joint. Because the sooner that joint starts moving properly again, you've got blood flow coming in, which flushes out the metabolites, waste products, toxins, and all the things that cause it to be sore and sensitive and inflamed. It's bringing in the healing products. It also automatically takes away all the muscle spasm and the stuff that enhances the pain response, which is a protective mechanism at the time. It tends to be an overreaction from the body because it doesn't want to cause any further damage. But a lot of it is not necessary. So if we can remove the unnecessary stuff, isolate where the damage is or the pain is coming from, and get you moving as quick as possible, that's going to heal a lot quicker than sticking you in bed for three weeks. We're seeing it with surgeries now as well. And you look at the people who are going in for knee replacement, and the quicker they can get in, replace the knee, get you off the table, first thing, you're not having any adverse effects to your anesthetic or any other drugs that they're using to sedate you and keep you comfortable while they're operating on your knee. But the quicker they can get you up and moving, the quicker that use your sponsor. So literally within an hour of you having your knee done, you're walking, and they're forcing you to walk. Whoa. Now, go back 10, 15 years ago, that was never going to happen.
I'm so trying to underground that this. Just say knee up, and you're walking after.
Within an hour, they brought you up and looking. And that's what it is about. Our bodies are designed to move. And if we're not moving, we're in trouble. We're decaying. And literally, that is one of the biggest killers. And it sounds genetic, but it is. One of the biggest killers of us is sitting. We were never designed to sit. And most of us spend the vast majority of our day sitting. If you think about it on this level, which is quite fascinating, when you sit, you're not sitting upright, getting your shoulders back. You can't sit like that for 8, 10, 12 years. So we all sit like this. So what happens when you sit like this? You've gone and collapsed your lung capacity by probably anywhere between sort of 15 and 30, maybe even 40% of that capacity. Now, one of the fundamental things that keeps us healthy and keeps us functional as human beings is oxygen in our system. If we don't have oxygen pumping around our arteries and going to the right tissues, so tissues start to decay. And it's that decay that leads to degeneration, which is low-grade inflammation in your system, which leads to further degeneration, which leads to pathology, and that's ultimately what ends up leading to our demise. Now, when you spend 10, 12, 14, 16 hours a day in this position, and you've lost...
And then driving, and then
and you've lost 40% of your lung capacity. That's 40% of your life oxygen that you've never taken into your system. That speeds up all the degeneration pathways, the decay over time. It sounds extreme.